Hello, my name is Myungsu Lee, the first author of the article. This is a great pleasure to publish our research in Korean Journal of Radiology, and we are honored to have privilege to present to listen to authors section. Also, I would like to thank all the collaborators who made great efforts to conduct the trial and prepare the article. The title of our research is that Prospective Multicenter Korean Registry of Transcatheter Arterial Chemoembolization with Drug-Eluting Embolics for Nodular Hepatocellular Carcinoma, a 2-year outcome analysis. The study was supported in the form of a grant and provision of drug-eluting embolics by Biocompatibles UK. Chemoembolization is a well-known treatment modality for HCC. It has proven survival benefit and the most commonly chosen palliative option for the patients. However, it has a drawback, the technical heterogeneity. The procedure consists of 1. Making and delivering chemotherapeutics, iodized oil immersion, and 2. Delivering emboling material. There is a significant technical heterogeneity in every aspect of the procedure. And chemoembolization with drug-eluting embolics, so-called DEE chemoembolization, the treatment of interest in the research, was developed as an alternative to the conventional chemoembolization with iodized oil. It utilized calibrated microsphere. It consists of a single step, preparation and delivery of emboling material loaded with chemotherapeutics. It is more homogeneous in the aspect of technique, and by this single step we can deliver drug and embolize the vessels at the same time. It was developed to have more controlled, sustained drug release with intention to make better local regional tumor control effect and minimize systemic adverse effect. DEE chemoembolization proved its concepts on clinical and early clinical studies. However, following clinical trials showed conflicting results in comparison with conventional chemoembolization. DEE chemoembolization, now known to have better or comparable safety profile, but failed to prove its superiority in the aspect of efficacy. The purpose of the study is to assess patient survival and tumor response outcome on DEE chemoembolization in the patients with nodular HCCs. It was conducted in Korean population, and the design was prospective multicenter registry-based trial. Target population was 200, and now we are presenting 2-year outcome. We recruited the patients from May 2011 to April 2013. Here's the key inclusion-exclusion criteria. The diagnosis was made clinically or histologically, and we included nodular HCCs, not infiltrative, excluding unmeasurable tumors. The patient had good performance status and relatively preserved liver function. We excluded invasive or metastatic or very high burden tumors. The patient with unbarriered below-enteric communication were excluded in concern of infectious hepatic complication. We used DC bead as drug-eluting embolics, the first one commercialized in Korea. As a standard procedure, 100 to 300 micrometer embolics were loaded with 70 to 75 milligrams of doxorubicin. Super-selective procedure was recommended whenever possible with 2 to 2.4 French microcatheter system. Embolization endpoint was near stasis. A cycle of treatment was defined completed when all the viral tumors identified on the imaging studies were covered by the DEE. For safety, up to 2 vials of DEE was used per session, and if insufficient, split session treatment was performed in 2 to 4 weeks interval to complete single cycle. These are the recommendations per protocol of the trial. However, actual procedural details were determined by operators concerning the status of the patients and the tumors. After the reference treatment, regular clinical visit was performed. Tumor response assessment was performed in the first, third, and sixth month, and on every third month thereafter. Repeat treatment was performed in on-demand setting. Conversion to other treatment or supportive care was allowed when the treatment was not effective or clinical performance or hepatic deterioration was present. The collected data was reviewed by 3 independent reviewers who did not participate in the execution of the trial, and consensus was made. We performed per patient and per lesion assessment separately. Tumor response was determined based on the MRECIST criteria. The number of target lesions was limited to 2 per patient, and the response was categorized into CR, PR, SD, and PD. At the time of progression, the cause was determined as LTP, IDR, VI, and EDM. In per lesion assessment, individual target lesions were assessed similarly by the diameter of arterial enhancing viable tumor as described in MRECIST. In per patient analysis, we measured the OS, PFS, and LTP-free survival. Tumor response was assessed till PD or expire, and the patient was excluded or censored from analysis when there is follow-up loss or referral, or when the patient underwent treatment other than the chemoembolization. In per lesion analysis, per lesion tumor control was measured. Tumor response was assessed till per lesion PD, and lesion was excluded from analysis when there is no more imaging study available or the lesion was targeted by non-DE chemoembolization treatment. On safety, we reviewed all the medical records and events. Specifically, the presence of post-embolization syndrome was assessed. For hepatic complication assessment, we also sought the findings suggesting liver abscess, biliary injury, or infarction. Serious adverse event was defined as follows and reported. In statistics, following analysis was performed. The final population consisted of 152. Here's the demographics. About 80% were male and mean age was 61. 70% of the patient had very good liver function of Child-Pugh score of A5, and 3/4 had the performance status of 0. In the tumor demographics, largest tumor size was 3.6 cm in mean and 3.0 cm in median. 55% had single, 45% had multiple tumors, and about 30% had bilobar disease. The BCLC stage, about half was stage A. In per lesion analysis, there was 207 tumors. The size was 2.2 cm in mean and 2.5 cm in median. About 30% were small tumors less than 2 cm in diameter. 55% had a size between 2 and 5 cm, and 15% has more than 5 cm in size. In the reference first cycle treatment, the most of the cases used 100 to 300 micrometer embolics. Mean amount was 1.02 vials and 68 milligrams of doxorubicin. Additional bland embolization was performed in 18% of the cases due to so-called vascular lake phenomenon. DE delivery via extrahepatic collateral was performed in 7 cases. During 2 years, total 254 cycles of the chemoembolization was performed, and collateral DE was performed in 10%. The slide shows tumor response and clinical status at the time of tumor response assessment protocol termination in 127 patients. At the time of termination, 65% were in PD status, but 35% were in non-PD status, unintended termination. In patients with non-PD termination, 2/3 were due to application of other treatment modality, most commonly conventional chemoembolization and RFA. In tumor response analysis, we can see the CR and OR rate both goes down through 2-year period in both per patient and per lesion settings. 2-year per patient CR/OR rate was 19.6% and per lesion CR/OR rate was 33.3%. Here is a big busy table summarizing the results of tumor response and survival analysis. We can see that child Pew score, tumor multiplicity, tumor distribution, BCLC stage, Okuda stage, modified UICC stage correlates with the various outcome measures. We can see the details in the figures. This is survival curves. Cumulative 2 years overall survival rate was 79.7%, progression-free survival rate was 22.4%, and median survival was 9.3 months. Local tumor progression-free survival rate was 28.8%, and median survival was 11.5 months, a bit higher and longer than PFS. In overall survival, child Pew score was the only independent predictor of survival. In progression-free survival, child Pew score, multiplicity, and tumor size was independent predictors. In A5, cumulative survival rate was 27.2%, median survival was 12 months. In A6, B7, they were 11.2% and 6.4 months. In LTP-free survival, child Pew score and multiplicity was independent predictors. 2-year survival rate and median survival were 38.8% and 16.9 months in a single tumor patients, and 15.2% and 7.2 months in multiple tumor patients. In per lesion tumor response analysis, 2-year cumulative tumor control rate was 36.2% and median time was 14.1 months. Child Pew score was the only independent predictor of per lesion tumor control. Even though the p-value was higher than 0.05, the tumor control rate curve looks interesting. The tumor in 2 to 5 size had highest 2-year cumulative tumor control rate of 42.2% and longest median time of 17.7 months. In safety, PES was reported in about 2/3 of the patients. Prominent bile duct dilation or bile duct injury was present in 20%. SAE was reported in 7%. Discussion. The strength of this study is that it has relatively large population and prospectively conducted in multiple centers. Such trial was seldom reported in Asian countries. The results in 1-year CR and OR rates and median progression-free survival or TTP and 2-year cumulative overall survival was comparable to previously reported measures, but 2-year CR rate was seldom reported in previous reports. Chemoembolization is a kind of local treatment modality, so local tumor control is an important marker of the effectiveness. So we try to refine the data to assess the impact of the chemoembolization by excluding the patients or tumor when the other modality was applied, and we conducted detailed longer-term per lesion tumor response assessment. As a result, we can see persistently deteriorating response rates in longer follow-up period up to 2 years, even after reaching complete response. So we can emphasize the importance of long-term response monitoring. Local recurrence may arise at any time point. As mentioned earlier, even though it was not statistically significant, it was beyond the usual expectation that smaller tumors will have better response after a certain kind of local treatment. In this study, tumor in size of 2 to 5 cm had better outcome than the others. Possibly, unlike the oil liquid used in conventional chemoembolization, the particulates with their own size cannot penetrate deeply into the smaller tumor-feeding arteries in the smaller tumors, resulting in insufficient drug delivery and embolization effect. Another finding to remark is that child-pugh score, a well-known predictor of survival in patients with HCC and chronic liver disease, is an important predictor of survival and local response in per-patient and per-lesion analysis. It appears in every analysis as a predictor. We cannot determine the cause of this finding. However, it is possible that peribiliary plexus hypertrophy, which takes place with advanced liver cirrhosis, can act as a collateral pathway of blood supply after chemoembolization. Also, vessel tortuosity with advanced liver disease and liver shrinkage can prohibit selective chemoembolization procedure, which will compromise the effectiveness of the procedure. The major limitation of the research is that a third of the patients were excluded from the protocol in non-PD status. 2/3 of them were due to receiving other treatments. The original design had ethical intention not to restrict the choice and application of second-line treatment, not to deprive the opportunity of the patient to get the best tailored treatment. This can be a significant shortcoming, however. As a result, it may reflect the results of the chemoembolization in real-world practice pattern in Korea. Aforementioned unexpected, not-so-good outcome in smaller tumors might have affected the choice to abandon the DE chemoembolization. In conclusion, the chemoembolization for nodular HCCs in Korean population seems effective and safe in 2-year follow-up. Good liver function was an important prognostic factor for PUL patient OS, PFS, LTP-free survival, and per lesion tumor control. Thank you for your attention.